Hey, I'm Jibi, nurse practitioner working in primary healthcare practice in Right Focus Healthcare LLC. Regarding my clinical experience, I have 3 years of pulmonary and primary care nurse practitioner experience, and I was an RN for 18 years. Today, we are going to do an educational review of COPD for primary care nurse practitioners who are practicing. I have done 2 videos. One is asthma inhalers and asthma management. I recommend watch that before this video. How do you define COPD? Chronic obstructive pulmonary disease. It's a common preventable and treatable disease which is characterized by persistent airflow limitation that is progressive and associated with chronic inflammatory response in airways and the lungs to cigarette smoking or noxious particles or gases. COPD includes chronic bronchitis and emphysema. It can be both together too. What is the difference of asthma and COPD? Asthma is curable while COPD is non-curable, even though treatable and preventable, and some treatment modalities are different. Let us discuss about prevalence. In 2022, 11.7 million people in the United States, or 4% of adults, had a diagnosis of COPD. Gender, more than half of the people diagnosed with COPD are women. Cost, COPD account for lots of billions of dollars in healthcare cost each year. Mortality, COPD is the 6th leading cause of death in the United States. In 2019, 3 million people died because of COPD. Prevention, COPD often can be prevented by not smoking. Causes of COPD or predisposing factors of COPD. Number 1, tobacco smoke. 60 to 90% of COPD is the major cause is tobacco smoke. The risk of occurrence of COPD in individuals is more with the more years of smoking and the amount of cigarette packets. Number 2, non-smokers who work in factories. The risk of occupational and environmental exposure, pollution with the dust and chemical fumes. Number 3, chronic respiratory infections. Untreated bronchitis can lead to COPD. Number 4, hyperresponsive airways such as asthma. For example, long-term asthma patients can turn into COPD. I have seen many cases in the clinics. Number 5, genetics, which is also number 6, alpha-1 antitrypsin deficiency. The body is not producing enough alpha-1 antitrypsin, which is caused by a change in the coding of the SERPINA gene. Alpha-1 antitrypsin is a protein produced by liver which protects the body from tissue damage. Who should be checked for it? If the patient is less than 45 years and has a history of alpha-1 antitrypsin deficiency in the family, and who could, the symptoms of COPD, shortness of breath, wheeze, cough, unexpected weight loss, recurrent respiratory infections, they should be checked for it. And it can be done by a blood test. Let's do a quick review of the respiratory mechanics. What happens during breathing? The air enters to the body through the upper airway, goes through the nose, upper airway, trachea, and then goes to the lower respiratory tract, which include 2 bronchi and bronchioles and alveoli at the end. What happens during inspiration? The diaphragm contracts and thoracic cavity increases in volume. Then that decreases the intra-alveolar pressure, so air flows into the lungs. So that means inspiration draws air into the lungs. Expiration is the process of letting air out of the lungs during breathing cycle. During expiration, the relaxation of the diaphragm and the elastic recoil of diaphragm. What happens then? That decreases the thoracic volume but increases the alveolar pressure, so the expiration pushes the air out of the lungs. Why it's important? The official diagnosis of COPD is done by the ratio of FEV1 and FVC, which is forced expiratory volume and forced vital capacity. That is why it's important. How do we diagnose COPD? Number 1, medical history. Ask the patients about episodes of cough, shortness of breath, wheezing, sputum production, frequency of respiratory infections, use of inhalers, and duration of symptoms. Number 2, physical exam. Observing the chest shape, symmetry, for example, barrel chest in emphysema, and listen to breath sounds, adventitious breath sounds or wheezing. Blood test, we already discussed about alpha-1 antitrypsin deficiency. Also, we can do general labs or iron deficiency. Chest X-ray is cannot diagnose COPD by its own, but it can rule out other conditions which can cause symptoms similar to COPD. But in general, COPD chest X-ray can look flattening of diaphragm or air pockets or enlargement of lungs in general. Next, the confirmatory diagnosis. The official diagnosis is made by breathing test or pulmonary function test. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD, recommends spirometry as a gold standard for measuring lung functions in patients with COPD. GOLD also combines two things along with the spirometry: the symptoms by grading the dyspnea symptoms, modified medical resource council, which is MMRC dyspnea scaling. Number 2, CAT, COPD assessment test, which is measurement of symptoms or exacerbations. When we work as a primary care nurse practitioner, sometimes we may not have the full pulmonary function test available. So we may only have patients already seen a pulmonologist and already on inhalers. So what we can do with them by the assessment of two things: CAT plus MMRC dyspnea scale, plus the use of rescue inhalers in a week, and how the current inhalers are helpful to them, or is still short of breath, or that is how, by the grading of the symptoms, we can assess the current medications are enough for them. Modified MRC dyspnea scale or MMRC dyspnea scale is a measurement of COPD symptoms per GOLD criteria. The range of grading is from 0 to 4. 0 is only get breathless with strenuous activities. Grading from 1, 2, 3, 4 means the patient get breathless even with a slight activity. So the grading is inversely proportional to the activity of the patient. And also, how do you remember this? The higher the grade in golden criteria, or the higher the gold grading, the patient has more symptoms and less active. Next in gold strategies for treatment for COPD is CAT assessment or COPD assessment for measurement of symptoms or COPD exacerbations. The range of CAT scoring is 0 to 40 on 8 items. For example, you can see the first line: I never cough. The grading is 0. I cough all the time. 5 is the score. On the 8th line, you can see I have lots of energy. 0 is the score, and I have no energy at all. 5 is the scoring. In summary, CAT scoring is inversely proportional to patient activity and directly proportional to symptoms. The more the CAT scoring in gold COPD, symptoms are more and patient is less active. This is very important to understand the next slide, the gold recommendation of treatment. How do you officially diagnose COPD? The FEV1 FVC ratio is less than 0.7. We can diagnose COPD. FEV1 is forced expiratory volume in 1 second, and FVC is forced vital capacity. Next is staging of COPD. Prior gold recommendation, it was only based on FEV1 measurement, and the treatment was based on the staging like mild, moderate, severe, and very severe. But with the gold classification, MMRC scale and CAT was added. And also the gold staging: gold stage 1, FEV1 greater than 80, gold 2, FEV1 50 to 80, gold 3, FEV1 30 to 50, gold 4, FEV1 less than 30. How do you remember this table? So when the gold stage is only 1, FEV1 is higher, or the limitation is less, and you need only a bronchodilator. But when the gold classification is stage 4, the higher the grading, the airflow limitation is higher. FEV1 is only 30, less than 30. So the patient may need a pulmonary rehabilitation and need oxygen. There are two phenotypes of COPD. Number one, chronic bronchitis, and number two, emphysema. As you see in the picture, in chronic bronchitis, the smoking can cause inflammation and results in narrowing of the airway or thickening of the airway. And so the cilia get damaged and the mucus or other particles get trapped in the airway, which results in mucus and pus, which is characterized by cough, chest pain, and shortness of breath. In chronic bronchitis, the cough is protective with the sputum. In emphysema, the alveoles are damaged, and there is, as you can see in the picture, there is large airspace. So there is decreased surface area in the alveoli, so there is obstruction of breathing, which is characterized by symptoms like shortness of breath, cough, which may not have to be protective like in chronic bronchitis, and wheezing. If you have listened to the video so far, this table is easy to understand. As you see, the GOLD strategy of COPD classification ranges from A, B, C, D. The higher the alphabet is, the patient is more critical. As you can see in the A category, CAT is less than 10 and MMRC is 0 to 1. So symptoms are breathlessness are less. And B, CAT is more than 10, MMRC is greater than 2, so a little more critical. C and D, as you can see on the right side, it's an indicator of the hospitalizations or exacerbation ranging from 0 to 2. So C and D have more exacerbations and hospital admission. Out of that, D needs more aggressive treatment because the CAT is more, MMRC is more, and then the hospital admissions are more. So out of C and D, D needs more treatment, but C and D are the more critical than A and B. Before we get to the COPD treatment, let's do a quick review of the inhalers classification. As you can see in the picture, the first line is SABA or short-acting beta-2 agonist, which are bronchodilators used to relax the smooth muscles and which helps in breathing. The examples are ProAir and Ventolin. You can see in the picture. And on the right side of the first line is LABA, which is long-acting beta-2 agonist. Examples are Surevant. Second row is inhaled corticosteroids, which is alone used only in asthma. Asthmanex and Flovent are examples. You have to make sure the patient knows they have to rinse mouth after use. And then the last row is LAMA or long-acting muscarinic antagonist and anticholinergic medications, which is by the anticholinergic activity, it reduces the mucus production. So it helps in the patients who had hospital admissions or exacerbations. Examples are Atrovent, Spiriva, and Incruse. Now, the most popular ones are the third row, which are the first half is LABA plus ICS. The examples are Advair, Dulera, and Symbicort. And Brio, the light blue one, is also in the LABA plus ICS. Then number two, on the second half of the third row is LABA plus LAMA, which is a popular combination for COPD. The examples are Anoro, TL2, and Bevespi. As you can see in the picture, these are different type of inhalers. There are metered dose inhaler, powdered inhaler, mist inhaler. And there is another combination, LAMA plus LABA plus ICS, 3 combination medications. The examples are Breztri and Trilogy, that is not in the picture. I'll highly recommend review my asthma inhaler video. There, the type and technique of all inhalers are explained in detail. But generally, as primary nurse practitioners, we can instruct the patients, do not take more than recommended dose. Number 2, when you are doing 2 inhalations at a time, give a 1-minute gap between each inhalation. And number 3, rinse mouth after use, especially if you are using, if the medications have inhaled corticosteroids. The treatment for COPD per the GOLD classification. If you have listened to the video carefully so far, this table is easy for you. As you can see, the higher the gold grading, the patients need aggressive treatment. In the group A, MMRC is 0 to 1, CAT is less than 10, so we will manage with the bronchodilators, which is example, ProAir and Ventolin. Group B, which is MMRC is greater than 2 and CAT is greater than 10, manage with the LABA, or which is Cerevant, example, LAMA, which is Incruse or Spiriva, Incruse 1 puff once daily, Spiriva 2 puff once daily. Then we'll go to group C, where the symptoms are less, CAT is less compared to D, but the hospitalization and exacerbations are, as you can see on the right side, is greater than 2. So we manage with the LAMA, example, Incruse 1 puff once daily, Spiriva 2 puff once daily, Atrovent 1 to 2 puff 3 to 4 times daily. But in the reality, in clinical settings, we get a group of patients in group B and C, where the patients will be on already LAMA plus LABA plus ICS like Trilogy, or LABA plus LAMA like Noro. So we can try to wean them off based on their MMRC and based on their CAT and the rescue inhaler weekly. We can wean them off the steroids or the LABA. Next is group D, where the CAT is greater than 10, MMRC is greater than 2, hospital admissions or exacerbations are greater than 2. So they need aggressive treatment. If CAT is greater than 20, LAMA plus LABA, or if the eosinophil is greater than 300, LAMA plus LABA plus ICS, or LABA plus ICS. The examples are Trilogy, 1 puff once daily, and there is a new one in the market, Breztri, it's 2 puff twice daily. A word about prevention of COPD. Smoking cessation counseling to the patient, advise them or recommend to them nicotine replacement therapy or gums or lozenges. Number 2, I forgot to mention, COPD occurs in patients who are greater than 65-year-old, so make sure they get the pneumonia and the flu shot vaccination. Number 3, encourage them to do more physical activity. Thank you for listening to this video. I hope this educational video to the nurse practitioner will help in improving your practice, especially when you're dealing with COPD patients. Thank you.